So we begin with our next lecture, which is on inhibitor screening and detection. So this is just a gist about, before going directly into inhibitors, we all know hemophilia A is the deficiency of factor 8, and they are classified into different types based on their factor levels and clinical severity as severe hemophilia, moderate hemophilia, and mild hemophilia. Now, the treatment of these patients is regular supplementation with either recombinant or plasma-derived factor 8 during the bleeds. But the problem is, because of these regular supplementation to these patients who do not have the factor 8, the immune system considers it as foreign, and 25 to 30% of these patients develop inhibitors against these factor 8. Once this is developed, the factor 8 is not the option of treatment because it doesn't work. So we have factor 8 inhibitors. In severe hemophilia patients, it's around 25 to 30%, whereas in mild hemophilics, mild and moderate, it's just 5%. So inhibitors in hemophilia, they are mainly IgG antibodies that neutralize the clotting factor. And the frequency is more in severe hemophilia, around 20 to 30%, whereas it's less in moderate and mild hemophilia, around 5 to 10%. So the median age at which the inhibitor is developed is less than 3 years of age in severe hemophilia, whereas for mild and moderate, it is 30 years of age. That is directly proportional to the number of times that first patient has been exposed to factor 8 therapy. Because they bleed less, they are exposed less. So now coming to the severity in mild and moderate hemophilic patients, when they develop inhibitors, they get a clinical symptoms like severe hemophilia. Now coming to the different types of inhibitors, you have high responding inhibitors and low responding inhibitors. The high responding inhibitors tend to be persistent, whereas the low responding inhibitors, which is less than 5 Bethesda units, they are transient. They may disappear within 6 months. So both the gold standard method is the Nijmegen Bethesda inhibitor assay. However, for very low titers, this may still be missed, and that is why factor recovery assays is one of the best methods to check this, which we will be going ahead with. Now coming to hemophilia B, it is very much less frequent in hemophilia B patients, that is less than 5%, and it is mostly associated with an allergic response. So as soon as you transfuse a hemophilic B patient with factor 9 and you see an allergic response, you should test for inhibitors in hemophilia B patients. When should one suspect an inhibitor development? If a patient fails to respond or gives a poor clinical response to the factor transfusion, when you have lower factor 8 and 9 levels than expected after infusion, this is the factor recovery test. Or if you see unsuspected increase in number of severity of bleeding episodes in a patient, unusual bleeding episodes in a patient, all this should make you test the patient for inhibitors. Now coming to children, it is very well known, it is the first 75 exposure days which is very crucial when the child is diagnosed. So it is shown that the first 75 exposure days is the time when a patient can develop inhibitors. And that is why for children, the inhibitor should be checked every 5 exposure days until the 20th exposure days. Exposure days is nothing but the transfusion. Then every 10 exposure days between 21 and 50, and at least 2 times a year until 150 exposure days. When it comes to adults, it can be done as a 6 or 12 monthly review, or when the patient fails to respond adequately to a factor which previously he's been responding to. Prior to surgery, you need to do an inhibitor assay if the recovery assays are not as expected, and if clinical response is suboptimal. If a patient is intensively being treated continuously for 5 days with a lot of factors, again, the inhibitors need to be tested. So as said, instead of 50 exposure days, now a study in blood has shown that it is the first 75 exposure days to a newly diagnosed hemophilic, which is very crucial for inhibitor development. And coming to the other risk factors, you have high risk mutations like null mutations, inversions, large deletions, which are risk factors for developing inhibitors. Intense exposure, infection, the first 75 exposure days, as I said, and for hemophilic B, if you see an allergic, it is allergy, you should test for inhibitors. So now coming to the main topic is the techniques for inhibitor detection. You have the mixing studies or the incubated mix test, that is the screening assay. Then you have the classical Bethesda assay. You have the Nijmegen modified Bethesda. You have ELISA and chromogenic assay, and you have factor recovery tests. So let's go one by one. Coming to this incubated mixing test, which is the screening assay. So in this test, you have 3 tubes. In one tube, you add the patient sample. In the second tube, you add the normal pool plasma. And in the third tube, you add a 1:1 mix of patient and NPP. You put these 3 tubes in an incubator and let it be at 37 degrees for 1 hour and 2 hours. And at 1 hour and 2 hours, you do an APTT. What do you do an APTT of? You do an APTT of the separately incubated mix. You do a APTT of this incubated mix, that is the third tube, and a APTT of that minute, that is just at that point, you will mix 25 microliters from the patient vial and 25 of NPP. So that is not an incubated mix, that's an immediate mix. Okay, so this is just the protocol, and now I will tell you the principle behind it. We all know that factor VIII inhibitors are time and temperature dependent. And that is why the principle is the 2 hours incubation is for the time, and the temperature is also very crucial for this. So if your patient plasma has inhibitors, in 2 hours time, the factor VIII which is given by the normal pool plasma, the inhibitors will go and neutralize them completely. And that is why in the incubated mix, after 2 hours, factor VIII from the NPP will not be able to participate in the coagulation cascade, and you will get a prolonged APTT. However, when you are mixing it immediately at that time itself, you have not given time to the inhibitors in the patient plasma to neutralize the factor VIII in NPP, and that will not be as prolonged. So the interpretation is when the incubated mix APTT is 5 to 10 seconds more prolonged than the separate mix, you can give the inhibitor is positive for screening and go ahead with a Bethesda. Okay, so now there is a big crossover here on this slide because World Federation, the ICMR guidelines and the international guidelines do not recommend this test. Accordingly, they have seen that many low titers are missed by this test, and that is why it's not recommended. But at the same time, it is the cheapest and most doable test, and that is why till date it is done in most of the developing countries as of today. So this is how the inhibitor results look. For an inhibitor negative, you can see that the incubated mix is equivalent to that of a separate mix at 1 hour and 2 hours. But for an inhibitor positive sample, the incubated mix APTT is more than 5 seconds prolonged than the separate mix. So here you may give a diagnosis that may be inhibitor screening positive, go ahead with Bethesda. Now coming to the Bethesda assay. Bethesda assay is considered as a very complicated test, but actually the principle is the same, and it is just the number of tubes which go in it which makes it complicated. So to define what is one Bethesda unit, one Bethesda unit is that much amount of inhibitors in the plasma which will reduce the factor levels of your control to 50%. This is the definition of one Bethesda unit. Now, the cutoff value used in quantification of inhibitors is usually around 0.6 Bethesda units, but this has to be standardized in each lab and taken a call. So at our lab, we do repeat the test for any value below 2 Bethesda unit again after 2 days to confirm that the screening, and do a factor recovery study too. So now going with the Bethesda assay, what is done over here? So you have the patient plasma. What is done is you make n number of dilutions of the patient plasma using a buffer. 1:2, 1:4, 1:8, and go on till 1:28 or more. Simultaneously, you take another rack of tubes in which you add normal pool plasma. Then add the patient's dilutions to this normal pool plasma in a 1:1 ratio. And once you've done this, put it in your incubator for 2 hours. Okay, along with this, there is a buffer control in which there is no patient plasma added. It's just the buffer and the normal pool plasma, which will tell you how much factor VIII is there in the control. Now, the principle is same as the incubated mix. What you have done is, the only difference is now you have a dilution range of your patient's plasma and you're incubating it with normal pool plasma. After 2 hours, if the patient plasma has inhibitors, it will neutralize all the factor VIII present in the normal pool plasma, and you will see it in the only difference here is instead of an APTT, after the 2 hours, you're doing a factor VIII assay. As I said, the definition of 1 Bethesda unit is that amount which would make the factor levels of the control plasma to 50%. And that is what you have to see in this test. So what is done is you will do a buffered, the control tube factor assay. Say the factor assay levels is 100%, consider it as 100% for the control. So that patient dilution, 1:2 or 1:4 or 1:16 or 1:28, whichever gives you a factor level of 50% is the titer of the patient. This is how the analysis and the interpretation and the report is given. For this, sometimes when the values come in between, you need a graph and you need to graph it out to give the exact titer to the patient. Now, what I said, the protocol was about the classical Bethesda assay. However, now it is the Nijmegen modification which has come into place, which is very important. That is, there are 2 things which have been done in the Nijmegen modified assay. One is you are buffering your normal pool plasma with 0.1 molar imidazole to pH 7.4. Why is this done? It is to prevent any pH shift from causing a wrong result during this 2 hours incubation. Second thing, you were diluting the patient plasma with a buffer. Now you have to replace it with a factor VIII deficient plasma. This prevents any dilution from other protein contents and etc., which may affect the result. And that is why it makes it more sensitive. The only issue with this is because there is factor deficient plasma, which you used to use as a buffer, it makes this test very expensive if you're using the commercial depth. And there is a third, which is not a part of Nijmegen modified Bethesda, but it is a very important point, which majority of the labs may not be doing, but should be done. Now, if a patient comes to you and the clinician has transfused them with factor VIII, they do not respond to that factor VIII. And that is why they send the sample up for the inhibitors. Now, in the body, because the factor VIII has been given, the inhibitor in the patient's body will be bound to that factor VIII which was transfused. And that is why that inhibitor will not be available for our tests, which we are doing. So either inhibitor test should be done after a washout period, which is not possible for majority of our cases because they are bleeding. What you can do in a laboratory is heat the patient plasma at 56 degrees for 30 minutes, centrifuge it, and then use the plasma. What happens with this test is all your factors are destroyed. Okay, but the inhibitors are there. So with this test, the inhibitors get released and they are there. All of the inhibitors are there to participate in the Nijmegen Bethesda assay. So this is a very important point to be done for the Bethesda assay prior to doing the test. We do it for all, regardless of whether the patient is transfused or not, for the Nijmegen Bethesda. Coming to the next is factor VIII antibody detection by ELISA. In our department, we have standardized an in-house ELISA, but you do get ELISAs even from outside. The problem over here with the ELISA, it has to be done batch-wise, but it is the pros about ELISA is it is not affected by lupus anticoagulant. Okay, so that is why this is good, but you cannot wait for collecting 100 samples and then do an ELISA. So generally, this is done when you have camps or such things which are already the camps basically. Now coming to when would you get false positive results? You can get false positive results if you use an EDTA plasma. So very important for all coagulation tests, use a citrated collected blood and that plasma. So EDTA being a strong calcium chelator, they cause prolongation of APTT PT and even they affect the coagulation tests. So this is one reason. Then second is lupus anticoagulant. We all know that very strong lupus anticoagulant actually interferes in all coagulation assays. Let it be even factor assays, let it be inhibitor assays. So this is one thing. Over here, in patients with very strong LA, a chromogenic or ELISA is very useful. There are other non-specific inhibitors like high titer. Now, if you have a high titer specific one factor inhibitor, it may cause even reduced levels of the others. So all this needs to take into consideration while giving the report and doing the assay. And there may be laboratory errors also. For example, the one which I said, if you do not do the heating step and you do, and the patient has low titer, that is 2 or 3, you may get a false negative result because they were not free to participate in the test. So coming to false negative results, as I said, you have recent treatment with factor or bypassing agents. Then inhibitor detection should be done after a washout, more reliable at the baseline levels, or you add this modification of heating the plasma at 56 for 30 minutes prior to testing. Then, now this was a first report which was published by us. Because we have done many inhibitor camps, after assessing around 4,000 to 6,000 samples, we found that we know that factor VIII inhibitors are time and temperature dependent. They are not immediate acting. But we found in some of our patients, they were immediate acting. That is, you can see at the 0 hour itself, the mix is absolutely not corrected. It is a very less percentage, but this does happen. So what happens in such patients is they have very strong LA, and the problem is they come negative in incubated mix test, and the Bethesda gives you non-parallel results, so you can't even do a titer of it. So approach at our end for in our institute, in our department, if we get a known case of hemophilia whose immediate mixing is not at all correcting, the general method, if you do an incubated mix, would give you negative results. But obvious, because at the 0 hour only the inhibitors have acted. So what is the use of seeing after 2 hours? Similarly, the Nijmegen modified Bethesda gives you non-parallel, non-linear readings and exaggerated titers. So for this, the best method for immediate acting is doing a chromogenic or ELISA. The problem is it's costly, and it's costly because you have to do only few samples. You wouldn't get that many. But this is the best method for this. Now, important unresolved issues which lie. There is still date interassay variability. There is a lack of appropriate standardization for the lower limit of inhibitor detection. There is a lack of definition of negative antibody titer. That is 0.6 should be considered, or 1 Bethesda unit should be considered. Quantitative assays are not cost effective. As I said, the Nijmegen modified requires a lot of factor VIII depth, and even for the dilutions and even to do the factor VIII assay. So that is why it is not cost effective. You have interference of many non-neutralizing antibodies, and especially lupus anticoagulant. So this is the ICMR data highlighting how the interlaboratory variations occurs in the factor VIII inhibitors, which should be resolved. And now coming to the factor VIII recovery test. Now, this is one of the best methods to see or to confirm that the patient has inhibitors. So if clinically the clinician thinks that no, even though we've given a screening of negative, the patient is not responding well, just transfuse the patient with factor VIII, and after 30 minutes or 15 minutes, collect the blood and send for factor levels before and after. So if the factor VIII levels come 66% or less, you may still consider that the patient may have inhibitors. So it is, we do this very often when we suspect that there are inhibitors, but it's not being caught. And it is an excellent test to determine whether the patient has inhibitors. So to conclude, inhibitor testing has to be done when the poor clinical response is seen, or when lower factor VIII and IX levels are seen in the laboratory test, then expected from the transfusion. Important is the first 75 treatments, and that is why the inhibitors should be tested during the first 75 exposures. Nijmegen modified Bethesda assay is the gold standard test for inhibitor testing, but you have LA interference even in that, and even for immediate acting inhibitors, the chromogenic and ELISA is the best. For very low titers, factor recovery test should be done. Thank you. One second. Questions?
You said that factor VIII recovery tests are better screening test for the inhibitor. So, then why are we going for
Rucha, can I ask you a question? Jasmina here.
Yes, ma'am.
Okay. So when we talk about the Nijmegen modification, all the patients' dilutions will also be made in factor VIII deficient plasma, isn't it?
Yes.
Yes. Okay. Thanks for that.
Okay.
And when we say the chromogenic assay you're going to use even for inhibitor testing, that means it's just the factor VIII assay part which is being done chromogenic.
Yes, ma'am.
Otherwise,
yes,
everything else is the same outside.
Correct. The dilutions, the incubation, everything is the same. The last factor assay is done by chromogenic.
Okay. So do you usually screen? Sorry, I'm hogging up the time. I hope.
No, ma'am. Ample time.
So in a routine where you get a lot of inhibitors to screen, I know your hospital really has done fantastic work in this and has published so much good stuff for all of us. So what is your usual policy? Would you screen with the ELISA and then do this clot-based test in the ones where there is positivity, or when would your ELISA come in? When do you push in your ELISA?
So, ma'am, ELISA comes in only for camps, since we have many camps which are going around. So yes, for the camps, when we already have 50 samples or more, we first put an ELISA, and all borderline and positive cases are then taken up directly by NIIMG Bethesda.
Fine. That's fine. Thanks a lot.
Yeah. Okay, and now your question for factor recovery test.
Factor VIII recovery, it gives better information than NIIMG modification.
The problem with that is the clinician will not always transfuse a patient who she suspects with inhibitors with factor VIII. It would trigger a inhibitor response. So this is just done sometimes when it's a low titer. You wouldn't want to do it when there is a high titer inhibitor. That is why that's not the main test. It's just a test for the low screening, which is missed by NIIMG. So there is a question, that is how to monitor for inhibitors after treatment. As I said, you can send the sample. It's just the laboratory has to add the extra step of heating the plasma at 56 degrees for 30 minutes. And then the normal assay of NIIMG Bethesda could be done. So, okay. Now I go back.
Can I ask another question, Rucha?
Yes, ma'am.
So do you take a call on how many dilutions to make depending on your the screen results, or do you make a standard set of dilutions each time?
So for an unknown case, now if it's a known case, we do know their Bethesda titer before, and then depending on that, we take a call. But for a new case, ma'am, initially we do a 1:2 and 1:4. If we get it positive, we put and we come to know from the 1:2 dilution what would be the range, then we put the entire panel.
Okay, so you do it in 2 steps. That means 2 hours each time, no?
Yes, yes.
4
yes.
hours. Okay, okay. Thanks.
So the question is, can PEG be used for checking the factor VIII recovery in patients if the factor VIII assay is not available? Actually, I wouldn't advise it, because the point of factor VIII recovery is to assess how much has been transfused with the levels which you've got. Using PEG, you would never get the exact factor VIII levels. So no to that. So I guess if all the questions are done, I would like to end today's lectures, and tomorrow we have important lectures by Dr. Prantar and Dr. Chandrakala ma'am on mandatory coagulation tests in hospitals and monitoring, along with management of hemophilia A patients with inhibitors. So I hope to see all of you tomorrow at sharp 10 a.m. Thank you.